Okay, welcome everybody. My name is Ellie Larson. I'm a fourth year medical student at the University of Washington, and I'm the chair of the Gun Violence Task Force here at Doctors for America this year. I will be moderating this panel, and I'm so excited to have you all join us for our advocacy grand rounds beyond the clinic, how physicians are transforming gun violence prevention. A couple of ground rules before we get started. First things first, I want to take a quick minute to invite you all to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying for your annual membership dues to support DFA's organizational stability and incredible programs like this Advocacy Grand Round series. There are four different levels to choose from, and a DFA member is going to put the link to join in the chat. We will be making a recording, and all material will be available of this grand rounds afterwards. Couple of ground rules. There's no such thing as a stupid question. And speaking of questions, please remember to use the Q&A feature. We will be addressing questions from the Q&A during the second half of our session today. Also, look out for comments in the chat. The DFA staff member today will be sharing helpful links during this session. And now on to our speakers. We're thrilled to welcome Dr. Gregory Engel. Dr. Gregory Engel is a family physician, epidemiologist, and public health educator with more than 25 years of experience in clinical care, medical education, and community health. He's a founding member of Ceasefire Northwest and currently serves as Vice President for Education, where he leads the development and expansion of public health-informed curricula designed to empower young people to prevent firearm injuries and build safer communities. His work has reached more than 16,000 high school students across Washington state through a comprehensive evidence-based educational approach, one of the only programs of its kind in the country, and has done so without generating complaints of political bias. A former disease transmission researcher and longtime clinical faculty member at the University of Washington, Dr. Engel continues to work at the intersection of science, education, and community engagement to advance effective prevention-focused approaches to firearm harm. Welcome, Dr. Engel. Our next speaker is Dr. Annie Basebeich. She's a pediatric emergency physician at Rainbow Babies and Children's Hospital, where she serves as the co-director of their Level 1 Pediatric Trauma Center. She is a native of Cleveland. She did her undergraduate and medical education at Case Western Reserve University. Following that, she did her pediatric residency at Cincinnati Children's Hospital and her pediatric emergency medicine fellowship at Akron Children's Hospital. She is a professor of pediatrics at Case Western Reserve University. Nationally, she is active in the Pediatric Trauma Society and the American Trauma Society. Regionally, she is the medical director for pediatric trauma at the Northern Ohio Trauma System. In addition, she is a member of the Gun Safety Coalition, as well as a board member for the Academy of Medicine in Cleveland in Northern Ohio. Welcome, Dr. Basebeich. And last but not least, our third panelist is Dr. Nathan Irvin. Dr. Irvin is an associate professor at the Department of Emergency Medicine and assistant dean for medical student diversity, equity, and inclusion at the Johns Hopkins University School of Medicine. He has earned his medical degree from Harvard Medical School in 2003. After medical school, he completed an emergency medicine residency at Alameda Health System's Highland Hospital in Oakland, California, where he served as chief resident and graduated in 2011. He then completed a fellowship in the Robert Wood Johnson Foundation's Clinical Scholars Program at the University of Pennsylvania, earning a master's degree in public health research in 2013. Dr. Irvin is a clinical educator and researcher committed to improving the health of vulnerable populations, including economically disadvantaged individuals and racial and ethnic minorities who disproportionately receive care in emergency departments. His scholarship focuses on health and behavioral issues affecting urban communities, including violence, trauma, HIV/AIDS, and substance use, often incorporating innovative humanities-based approaches to support change. He's the director of the fourth-year social emergency medicine-focused advanced specialty training program, where he mentors senior student projects focused on addressing social and structural barriers that affect patients' ability to achieve better health. He also serves as co-director of the Center of Health and Humanities in Emergency Medicine, where he equips learners to with the tools to understand and respond to the human experience of health and illness, and to see patients as individuals within their broader social contexts. In addition, he serves as the medical advisor for the Johns Hopkins Break the Cycle of Violence intervention programs. Welcome, Dr. Irvin. A little bit of a topic overview before we kind of get into questions for our panelists. I wanted to give. So overall, physicians think often about gun violence in our offices and hospitals and how to discuss gun violence with patients. If you're interested in learning more about how to discuss gun violence with patients, you can see our previous advocacy grand rounds on YouTube. But once we as physicians leave the hospital, often we don't know what else to do. For those who want to get involved with our community but often feel overwhelmed or don't know where to start, hopefully the next hour will leave you with a broad variety of what physicians can do outside of the office and give some inspiration for changing how we interact with firearms and violence prevention within our own communities. So with that, I wanted to start with just kind of a broad overview question for you guys. What drew you to becoming an advocate for gun violence prevention within your own community? And whoever wants to start, go ahead and jump in.
Annie?
I can start. As a pediatric emergency medicine physician, I basically got sick of taking care of children who were shot. And unlike my other two fellows on this webinar, I'm sort of late to the public health arena. But yeah, I got sick of taking care of kids who were shot, and I needed to do something about it.
Yeah, I think as a family physician and a person who's done a good amount of research, I put those two hats on together, and like Annie, I've seen a lot of violence and a lot of the sequela of gun violence in our communities. I see the families counsel them about loss of their family members, and then putting on the public health hat, taking a look at things from a 50,000 foot perspective, we can see the big societal trends and what drives this epidemic and how to fix it. So this is an exciting time, actually, for this field, I think.
I got interested in this, I think, for two reasons. One, I grew up in an area that was riddled with gang violence. There's a lot of Black and Latino violence. And that was kind of the context that I was raised in. And so, I remember being in high school and in college, in college at the same city that I grew up in. You go to a party and you knew it was over when they got shot up. Like that was a normal part of my existence. And then when I became an emergency medicine resident, I trained at Highland Hospital, which at the time was one of the most violent cities. Oakland was one of the most violent cities in the country, and Highland was the trauma center that saw all of those people. And I remember like being really excited about being an emergency physician. And, back then ER was the big show on TV, and you watched all these heroics about how like they resuscitate these trauma victims. And I was like, this is going to be amazing. And the reality of it was depressing. It was man after man who were around my age, who looked like me, who looked like my friends, looked like my brother, that were coming with bullet holes, many of which were unsurvivable. And I realized really quickly that the only way I would be able to endure a career in emergency medicine was if I felt like I was playing a part in trying to stop this from happening. And so I think certainly wanted to change the context so that other kids don't grow up with violence being such a big part of that background, but also, being able to have a career that's sustainable and hopefully one where future generation of trainees don't have to see as much carnage as we've had over the course of our careers.
Thank you, everybody, for sharing that. Can you guys tell me a little bit about the projects that you're currently involved in, things that you're doing within this sphere that you feel like have started to make a difference within your communities?
I guess since we're going, we'll go in order and I'll start. So I started very small. I got a grant to obtain and distribute gun locks to my families in the emergency department. I tried to get an IRB to gather some data, and of course, anonymous data is very hard to get. Um, and in the end, I decided I just wanted to get the locks into the hands of families. I had some motivated residents in the beginning. This was something new. We didn't know how to talk to families about screening for firearms in the home, and two future PZM fellows created a module that they taught to their colleagues. And I got my nurses and bought first lock I bought, having never handled a firearm in my life. I didn't even know how to do it, so I got one of those bright orange dummy guns off of Amazon. And, so now when I have families who go, yeah, I'd love a gun lock. I have no idea how to use it. I'm like, haha, let me show you my bright orange dummy gun and we'll figure it out together. And after that success rolled, I decided I wanted to expand my program throughout my hospital. And so I got a second grant that I was able to purchase more locks and some lock boxes and got them in all of my inpatient units at my children's hospital, as including my newborn nursery. So when kids are getting taught, the families are going home with babies and learning car seats and back to sleep, they are also being offered locks and lock boxes. And over the past 3 years, I've given away over 2,500 gun locks and probably about 250 boxes. So and it was just me getting fed up and trying to figure out, okay, what can I do? Get a small grant, start small, and get the ball rolling.
That's wonderful. So I started our education program in schools about 10 years ago. Kids, by the time they're 18 in our country, have seen an average of 200,000 acts of violence on television alone, many with portraying firearms. That doesn't count social media, that doesn't count movies, that doesn't count video games. We educate our kids on firearms. We give them the educations they see on the movies. That's not what the education they need to see. We've created a culture of firearms in our country, which is driving our epidemic of firearm injuries, which includes community violence, but also importantly, suicide and unintentional deaths, domestic violence, police violence. We need to have people with the information. So we started small in public schools. By now, we've reached over 17,000 students, 6,000 in the last year alone. Now we are working with a school district in Washington State, Edmonds School District, that has developed our program, which is delivered by healthcare providers, to deliver a program that's developed by teachers. That's the way it should be done. And actually, we have 85,000 students graduate every year from Washington State high schools. We need all 85,000 of those students to get this information. We need them to understand the facts, the data, the fact that what they see on television is actually not reality. We need them to understand that having a firearm in the home is associated with increased risks of suicide and homicide. We need them to understand how to identify people in their environment, both in their classes and in their communities, who are at higher risk for firearm violence, both committing it and being victimized by it. We know that 1 out of 6 kids between the ages of 12 and 17 think seriously about harming themselves. That means that's 5,000 suicide attempts every day in that age group alone in our country, right? We need these kids to have that kind of information because their safety is depending on the knowledge of the kid who's sitting next to them, their classmates, their teammates, their friends. How can we live in a country where kids are getting this information from the TV and not teach them the facts in schools? That is the institution where this stuff has to be delivered. And it will make our counseling efforts in our clinics and in our emergency rooms that much more effective. Because once we see those messages out in the community, it makes the things that we say to our patients that much more effective. Counseling, I've been there, right? I've counseled tons of patients about firearm safety. It's hard sometimes, particularly in communities like I worked for 8 years in Alaska, where firearm ownership is the rule. And that's the culture. So it's a challenge, but we need to have those community messages out there. And this is an exciting time. There are 3 states in our country that have just passed laws mandating firearm injury prevention education in K through 12. Interestingly, they're Utah, Tennessee, and Arkansas, not the states maybe you would expect. Ours is a holistic approach. This is the way I think we need to go. And I'm always enthusiastic to work with folks across in different states on this one.
So there's 2 initiatives that I want to bring up. One is I helped develop a program called Break the Cycle, which is a hospital-based violence individual program at the Johns Hopkins Hospital. Is now expanded to our Children's Center as well as to our Bayview Medical Center, and is now incorporated into our Division of Trauma. And so it's a wraparound program for individuals who've been victims of violence. And historically, these individuals would come to the hospital and they would be patched up for whatever injuries they had, and nobody attended to any of their high-risk issues that put them at risk of being injured in the first place. And historical data has shown as much as 45% of folks who come with a gunshot wound will return to the hospital within 5 years with similar injuries, 20% of which will be fatal. And so it's a really high-stakes game, and we provide these wraparound services to help address whatever barriers are in people's way from living a healthy life. And so our program has been in place for about, I believe, 5 or 6 years now. And to date, our recidivism rate is less than 3%. And so we do a really great job of working collaboratively with our partners all across the city of Baltimore. Baltimore is really invested in a citywide ecosystem to support people who are at risk or victims of various forms of violence. And it's all a city approach to this epidemic. And so there's that program that I work with. The other thing that I work with, I'm part of a team that has been working on a project called the ERPO Navigator Project. So ERPO is Extreme Risk Protective Orders. These are civil orders that can be issued if an individual is deemed at risk of harming themselves or others, like imminently at risk of harming themselves or others because of the behaviors they've been engaging in. And they're they own a firearm or they have control of a firearm. And so Maryland is one of, I believe, 7 states in the country where physicians or clinicians can actually petition the court to file an ERPO. And so as an emergency physician, I encounter lots of patients who are in the midst of crisis and potentially merit having one of these ERPOs filed against them. But one of the big drawbacks is that in order to do so, you have to go and testify in court. There's a whole process that has to happen, which is a huge barrier for physicians to really dive into this process. And so we developed a program in concert with one of our local mental health service agencies to have a ERPO Navigator, which is essentially a consult that we can call if we identify somebody whose family is concerned about them or we're concerned about them. We can have this individual come and help us assess that patient, and then to follow through with the judicial proceedings to help keep that individual and the community safe. And so that's a project that we're also working on. So trying to attack violence from different angles.
Thank you, everybody, for sharing. Those sound like really worthwhile projects, and I'm excited to kind of see where they all go. Um, my next question is, what motivates you to continue your work despite or whether you get pushback from both the community advocates or policymakers?
For me, it's easy. I think the alternative, seeing somebody dead or severely injured for something that's preventable is unacceptable, right? So having somebody be upset with me or disagree with my ideas about how we should keep our community safe, I'm okay with that. Like those are, largely arguments that don't cause me any harm. I don't take any offense to it. But I think for me, like every single person I see that is a preventable injury, a preventable death like that, it's a death of a thousand cuts to me, right? And I think it's far harder to look somebody's loved one in the eye and have to pronounce them dead and tell them what happened to them than it is to address any blowback that might come from working in this space.
Oh, so one of the surprising things, and I'm one of the wonderful experiences I've had working in this area has been that I'm constantly surprised because I came to it like so many people with boatloads of assumptions, and I've been proved wrong so many times, and that's been a pleasure actually. But one of the things that I've been proved wrong was when I started teaching in schools, I assumed that I was going to get pushback. I assumed I was going to get contacted by the NRA. I assumed that conservative legislators were going to be knocking on my door and I was going to be getting bad press. And one of the delightful discoveries I've made was after teaching 17,000 students, and not just in Western Washington, which is a progressive area, but also in Eastern Washington, where there are conservative communities where firearm ownership is quite prevalent, is that I've yet to have a single complaint from a parent, a teacher, an administrator, or a student that our program is biased, either pro-gun or anti-gun. And that's simply because we talk about the facts. And when I speak to legislators in Washington state from conservative districts, as I have the last 6 of them in the last 2 weeks, they sign on to our proposition of saying, yeah, do you need to teach in schools? Yes, we need to teach schools. We need to teach students in high schools. We need them to know the facts. Now, will they stand up and be counted? No, because they all believe that as soon as they support a proposition like that in public, that they'll be voted out of office. What I want to do is I actually want to test that proposition because that's the assumption that everyone makes. Actually, people from scholarly circles make that assumption as well, that we're going to get pushback. And maybe it's just not the case.
I'm fortunate that since I am currently having I have a small program, I have the support of the administration at my children's hospital. I tread lightly and remain apolitical, which I think we all have to. And when I talk to parents and when we all talk to parents, we have families, we have to say, I don't want to get into the talk about whether or not I'm not trying to take away your guns. I'm just trying to keep you from, having your kids get shot or your family get shot or your teenagers get shot. So, I have not stepped outside the boundaries of my hospital yet, but I'm getting there.
Yeah,
If I,
I think
yeah,
I was just gonna add, like I think it's important to surround yourself with people um, who come at it from different angles because I think like having that perspective is useful for being able to really have a meaningful dialogue to come up with some solutions that are practical and might be useful, right? Like, I think like at Hopkins we have the Center for Gun Violence Solutions, and there are plenty of people in there who own guns themselves, right? That are also working on ways to keep people safe. And so I think like the more you recognize that we're all human, we all value life. We want our family members to survive. We want our communities to be safe. These are like shared values, and like you try to connect on those things, and then you can come to some meaningful solutions that like help move the needle forward.
I mean, you just look at us three panelists, and we're in various parts of the country. We look very different. When I first started, my program, one of the surgeons who has since left, he goes, "Why does one middle-aged white woman want to start getting involved with, gun violence in Cleveland?" And but it's you realize that we're all different faces and different backgrounds, different parts of the country, and all have the same cause. And the more that our the rest of the country can see this, the rest of the world can see this, that we can all be, look different, have different backgrounds, different races, different sexes, but all have the same cause.
And I know we've kind of already touched on this a little bit, but I want to kind of come around to like what strategies have you found effective when talking with people about gun violence prevention? And we have, people from all three of you are kind of from a different angle of both medicine and walks of life, between like pediatrics and adult medicine. What has worked and what has not worked when you start trying to talk to people?
I think that one thing that I've been impressed with is the important role of language. And actually, I'm not good at this because as I reflect back on the words that I've used in this panel discussion, I have continually violated my rules. But I do my best. Firearm owners would like to hear the word firearm. They don't want to hear gun. Does it make a difference to me? It doesn't. Does it make a difference to them? It does. And so I'm very happy to shape my language to respect their perspectives, because they're critical as participants in the solution here. They would like to have people to have the feeling that there is some sharing of experience. So I had a great opportunity living in Alaska to live with people for whom firearms were a part of their lives. It was a subsistence hunting community where everyone owned a firearm, literally, in the northern part of Alaska. And it was a good opportunity for me to actually go out and train with folks and see what it was like. Did I decide to own a firearm? I decided not to. And I decided that I knew the reasons but I could share that perspective at least and honor where they were coming from. The more we listen carefully to people, the better we can share with them on safety decisions.
I I think a year or two ago, Annie Andrews came and gave a grand rounds at our hospital. And one of the pieces that I took away was that you don't ask people if they own a firearm. When you're doing does your kid wear a bike helmet? Do you have your car seat? And you're doing all of your anticipatory guidance for children. You just say, how are your firearms stored in your home? How do you store your firearms? And then if the family goes, I don't have any, well, okay. But instead of putting somebody on the spot and giving them that feeling that they have to be defensive, well, do you own a gun? So and again, I try very hard to remember, much like what you were saying, to call it a firearm and how do you store your firearms as opposed to saying, do you own a gun? And then for me, I'm sorry, I had a blank. Um, we have advertisement around our hospital, around our emergency department, big, big, clever signage. And sometimes I'll just walk in rooms and say, I don't know if you've seen the signs, because not every family will ask. And just say, hey, we're giving away free gun locks today. If you need one, let one of us know. And then I just step out of the room and I let them think, I let them ponder. And then invariably I find somebody is, they've told the nurse, they've told the social worker, they told the resident, and we're, shipping them off. And every day I'm refilling the bin.
Yeah, I agree with both Greg and Annie have said. I think it's really about relationships and really building relationships. A lot of the patients that we work with who've been victims of injury and or sometimes perpetrators of injury, you really have to build trust, right? You gotta get that person to understand that you're not judging them, that you are, you want to work with them to prioritize their health and in safety, and that questions around retaliation and stuff like that, like those are normal feelings to feel when you feel hurt. I think for me and the folks I work with, I think really embracing those kind of conversations and meeting the patient where they are, and helping them work through that, I think is where a lot of the richness is, in the types of patients that I tend to work with. When I'm talking to policymakers or testifying on the Hill, I think I use a different approach. I'm a physician, and I think the narrative of a patient is far more powerful than statistics and a lot of other things that we typically use if we're giving a traditional dialogue, or lecture about something. And so I will use those narratives. I'll use those types of stories, to try to meet those policymakers or those individuals, utilizing a different lens. And so I kind of use the power of all the different types of patients that I've interacted with to be able to kind of sell what I think is the message I want them to leave home with. But I think, irrespective, I think you got to lean in, you got to meet people where they are, you got to be non-judgmental, and I think find those commonalities that really, we all hold dear. We all want to be safe. We all that is part of being human. And if you can connect with people on that level, then I think you can have some meaningful conversations and hopefully get them to do things that'll be positive for them.
Thank you, everybody, for those strategies. For our audience members, I just want to remind you to put your questions in the Q&A. Hopefully we can go through kind of one more question of mine and jump to the Q&A if people have things. So just go ahead and put your questions down there. If someone wanted to get involved in your work of gun violence prevention or firearm prevention, how would they do that, or how would they start something like you've been doing in their own communities?
I am always delighted to hear from people, and I've tried to reach out to groups around the country. There's a group of physicians in Michigan. Hopefully, they'll be inviting me and arranging a classroom so I can demonstrate what we do in the classrooms. We're working across the border in Oregon to get our work incorporated in Portland, taking some steps to move things around. I would absolutely invite everyone to contact me by telephone or by email. You can come by my house, but would love to talk to you, and you'll have to make me stop talking. But Ellie has actually worked with our group of medical students at UW for the last 7 years. Actually, the group has been going for 7 years, and Ellie's been part of it for 3 years. So we're getting medical students sometimes into the classrooms. Ellie has taught in the classrooms. I think it's a good experience for young doctors to do that. And there are lots of different kinds of aspects of what we do. We do research. We've published our first paper in the Journal of School Health that documents the work that we're doing and shows that kids who get taught by us um, learn what we're teaching. It's not rocket science, but it demonstrates that it can be done, and it is being done, and we do have the tools. So yes, if you have any thoughts of taking this ball and running in your own location, please give me a call. Should I put my address in the chat? Maybe I'll do that.
I was going to say, I might actually take you up on that offer.
Yeah, I think you just gotta lean into it. Honestly, I remember I was a resident and I was struggling with this, um, and I read this book, "Wrong Place, Wrong Time" by John Rich. And this is before, like, you could get on Instagram or LinkedIn and find people. So like I was screwing the internet to try to find his email address. And I just cold emailed him and I was like, hey, I read your book. It just transformed the way I think about violence and youth violence. Um, I want to be like you. Can we do a call? And he invited me to dinner, and like that set me on a trajectory to really kind of dive into this work. And so I think you just have to lean in and be willing to just work at it. When I was a fellow, I did some work on like firearm policy, and I kept hitting walls. But you just got to be stubborn and just keep going after it. There's a whole community of people around the country who are working at on this from different angles, and really working to figure out how we can make things better. And so yeah, I think um, uh, find people who are doing the things you're interested in and reach out to them. And this community is very welcoming and would be willing to have you join and have you learn as much as possible and try stuff out at your shop. If you're interested specifically in hospital-based violence intervention programs, there's an organization called HAVI, the Health Alliance for Violence Intervention, and they actually do a lot of work to help make it easy for hospital systems and hospitals to stand these types of programs up. And there's classes that you can take, there's trainings you can do, there's like workshops that are directed towards helping you stand that type of initiative up. And so there are things like that also exist. But yeah, I just say dive in and try it. If you're a researcher, do a study looking at something. If you're an educator, figure out how to create a curriculum around this. Use whatever is your strength, whatever your talent to dive in.
And don't be afraid. Don't be afraid to be the one person to start something. And don't be afraid, everybody that I have met, from being the one woman with the wagon full of gun locks in her hospital, and one organization in Cleveland reached out to me, and then that organization, and then that one of those people connected me with, and you realize, and then you start meeting people, and you know picking the brains of people and getting other ideas. But, don't be afraid to just be that one person to say, all right, you know what? I'm just gonna dive in and see what happens. Because, in a couple of years, I've got a pretty good program established. And one of the other things that I just anecdotally we discovered was that our employees were inquiring about the ability to get locks and lock boxes. And one of the things that we looked at in the medical literature is there's not a lot out there about hospitals supporting their employees for or firearm violence protection or prevention. And so what I've done is I've done a couple of lockbox and gun lock giveaways in our cafeteria at lunchtime. And figured if we're gonna if we probably need to empower our employees to be able to then go forward for our patients. And that has been extremely well received, that our hospital, that they can come up and I've had people who've come up, 2 times in a row, and they said, "Oh, last time I got it from my father-in-law, and this time I'm going to get one from my cousin." And but you also, support the people around you in addition to your patients.
Great. I think one question that we had gotten a little bit earlier, I think Dr. Ingildis was directed at kind of your comment about the 3 states that have implemented school requirements for firearm injury prevention. Is there something that, as community members, how can they advocate or implement that kind of thing in other states? And if either of the other two of you have ideas of like how to get this advocacy into a broader region, that would be great.
Well, I think this is exciting times. Those states have passed laws. That doesn't mean that they're teaching students, and I don't know what they're teaching. In fact, that's the subject of research that we're doing, and trying to find out how these rules and laws are being implemented in different kind of states. My sense in the early stages is that it's not what we really would like to be done, but maybe it is a first step. It's actually having a conversation. And actually, we're in a place in our country where, if you notice, unfortunately, there will be a mass shooting, a school shooting that will hit our consciousness in the next weeks and months. And when that happens, notice what happens. There will be people who stand up and say, our hearts and minds are with the victims and the families. Absolutely appropriate. And then there'll be people who stand up and say, we need common sense gun control laws. There is absolutely an important place for that. But we are not yet at the place in our country where people will stand up and say, we need to educate people. And that's actually one of the basic principles of public health. When you are faced with a big problem in public health, there are 4 tools: research, technology, education, and laws. In our state, we have passed 13 laws in Washington state, good laws over the past 10 years. And yet our gun deaths have doubled between 2013 and 2023, and goes to what Dr. Irvin said before about ERPO laws. We have an ERPO law, an extreme risk protection order law in Washington state that was passed in 2016. And of the 17,000 students I've taught, 19 knew about that law. And I taught a class a couple of weeks ago of EMTs, 20 adults, none of whom knew about our extreme risk protection order law. We are not getting it done when it comes to education. We can do a lot better, and this is the time to do it.
Thank you for sharing that. Another question, Dr. Urban, would you share more about your Break the Cycles program? What does the program involve, and how is it received by both participants and the broader community?
Yeah, so our program has the way it works is we have individuals that are called violence intervention specialists that are on staff with us. And they are individuals who have a lived history of with violence, either as a victim and or a perpetrator of violence. And they've changed their life around, or they've healed from whatever the injury was, and they want to use that experience to help others who are dealing with that. And so we have currently 3 violence intervention specialists who are remarkable humans that reach out to every patient that comes in that is either shot or stabbed across our hospitals. But there's also a consult that can be made if there are individuals who have experienced IPV or other forms of violence that didn't rise to them being activated as part of like a trauma alert or something of the sort. And so they'll meet these individuals at bedside in the hospital, and they establish a relationship with them. They identify what their needs are. They identify what their like risk of retaliation is. They get an idea of like some of the circumstances surrounding what what was involved in that person being injured, and then we work with our partners across the city to figure out how we can support that individual, right? So there are some patients where the answer is we need to have that person relocated to a new place, and we'll work with the systems to figure out how to do that. There are other people who, you know, it might be a financial issue. Um, and we need to figure out how we can get somebody gainfully employed so we can get them connected to our resources in the city that help with employment. There are people who actually have been victims of violence, survivors of violence is actually what we call them in our hospital, and recovered and worked with our program and then gotten jobs within Johns Hopkins, which is one of the main employers in the city of Baltimore, right? And so they're now gainfully employed and doing well. And so we try to work with the patient to identify what are the needs of them or their family, and then we will kind of co-manage them longitudinally with other resources across the city of Baltimore. And so like the mayor's office of neighborhood safety and engagement has a lot of resources that they've stood up to help support folks. There's a organization in Baltimore called ROAR that's out of University of Maryland, Baltimore. That's a legal advocacy organization. And so they do some counseling for folks. They do a lot of legal aid for folks. And so we really work the system across the city of Baltimore to figure out like how do we right size what this patient needs with the resources that are available, and we try to do so in a trauma informed way. And I think ultimately, like we lean into those conversations intently and try to see that person for the human that they are and reach them on that level. And so I think it's just the extra touch, the extra effort to really help people who are going through some really difficult times in their lives and help them to get better. That makes it powerful.
And those wraparound services for the hospitals that have the programs for children are just amazing. You think about a child who has been a victim of a firearm injury and then they're trying to get back to school. They're having a hard time in school. They're having a hard time navigating because now they're in a wheelchair or they're, on crutches or whatever. And then, you think about all of the other issues that the family are facing, unstable housing, the program that we have for at Rainbow for wraparound services, will help get families, into some better housing, help the children in school, connect them, just simple connection with victims of violence, victims of violent crime. It's huge. And making sure these patients are getting screened for PTSD because, they're going to be having symptoms. And so, yes, prevention on the front end, but then, for those who are the victims, making sure that we've got the programs that are, completely, wrapping around these patients so that they can get back to their lives and even possibly a better way than they were in the first place.
I want to ask this one last question before I give you guys a couple of minutes to kind of give us your final thoughts because we're heading towards the end of the hour. But our last question from the Q&A is, we were doing an amazing job in cities like Baltimore, Chicago, when we had the funding for our CBI programs through federal funds. It's unfortunate that those funds have been removed, along with shutting down of the White House Office of Gun Violence Prevention. Homicide rates were even down 30%. How are you now supplementing that funding that has been removed?
We have a medical organization in Northeast Ohio that's the Academy of Medicine for Cleveland and Northern Ohio, and it's a very good advocacy group, and they did an amazing job of getting some reaching out to some of the big foundations in the Cleveland area and securing a grant to continue the violence interrupter programs at our two level one trauma centers in Cleveland that lost their funding. So, this is a time when you just have to, think outside the box and engage in your, get your local people to help. And, if you've got any kind of local philanthropic organizations, tap into them because it's hard with everybody having lost their funding.
Yeah, our program is actually funded by the hospital. The health system recognizes the importance of this. I think violence has been a big problem in the city of Baltimore. We are at historic lows. I think this past May there was 8 homicides in the city of Baltimore. It's the first time in May that there's been single-digit homicides in like 50 years, right? And so like the all of the hospitals in the city of Baltimore have really taken an approach that we're going to lean into this and really, be part of the big public health response. And so they fund the violence intervention specialists that are on the team, and then we have a couple social workers that are part of the trauma division that are already part of that workforce, and so we've integrated it into our plan. And then the city of Baltimore is also they recently won a big settlement related to like these ghost guns that were in the city of Baltimore. So some of those funds are being earmarked to be able to support the ongoing work here. And so, and then like there's philanthropy. Even the Ravens recently just gave like $1 million to some various entities in the city of Baltimore to that work on gun violence. And so, I think it's an issue that we all got to be in together. We're all going to be touched by it, whether you're in an urban area, rural area, whether you like guns or you dislike firearms, whatever the case may be, like we're all impacted by it. And so I think as a society, we just got to like lean in and play our part.
Okay, I want to be aware of everybody's time, but I want to give you guys a quick second to kind of sum up or give like one kind of idea that you want people to take away from what you've been chatting about tonight, before I kind of wrap us up.
Well, I think from my perspective that this is a multi-disciplinary approach to a multifaceted problem, not just community violence, gang violence. It's not just suicide, right? It encompasses big forces in our society: poverty and racism, cultural attitudes towards firearm ownership. And we know what works in public health. And we need to incorporate an advanced, sophisticated approach to this problem, which includes all those things. We need to continue our research. We need to fund community programs like Dr. Irvin's aggressively. And we need to educate people. We need to educate actually everyone. We need to educate them from early ages, through middle school, through high school. And critically, we need to educate people in the community so that I can't drive down the highway in 5 years and not see a sign that says, have you stored your firearm? Do you know what an ERPO is? When I can see that, those messages out there, because they're not there at all, almost, then I'll see that we'll start making some progress.
Mine's going to be very simple. Don't be afraid to have a conversation. I mean, it really is just starting with, meeting somebody and having an unbiased, open conversation.
And mine, I think, is gonna be similar around the education piece. I think for me, like one of the things that give me hope is, our medical students formed a group called Hopkins Med Against Gun Violence, which is like a, firearm and firearm advocacy organization. That's one of their student groups. And they advocated for firearm injury prevention to be integrated within our curricula. And so now there's literally at each stage of their training, there is embedded firearm injury prevention related information that they're receiving as clinicians. And so I just think, like, when I was a medical student, this was never talked about. This was like something completely separate. And to see this new generation hungry for tools to help keep people safe, and really like working to advocate to get that incorporated to their education. And to me, I think is a beautiful thing. And I know there's initiatives going around at a lot of the schools around the country, where students are asking for similar. And so, yeah, I think I second this need to educate not only our communities widely, but educate our docs so that we can speak to our patients, speak to our patients' families, and really use every touch point as an opportunity to make sure that we're keeping our community safer.
And if I could add a pep talk for everyone out there, as doctors, we're powerful. We are well situated. We know how the system works. We know how the system works as an individual and as a community. We have that understanding, and people want to listen to us. We can do this.
Thank you so much, everybody, for your closing remarks. I'd love to close this session by thanking you guys again for such a thought-provoking discussion. We are so grateful that you were able to join us tonight. Before you all leave, a few quick reminders. As we heard tonight, education is so important, and so is action. After tonight's session, I'd like to encourage some of you to take some following actions, such as writing an op-ed or a letter to the editor to your local paper about what you learned about tonight, sharing what you learned with colleagues or friends, and inviting others to join DFA's network. Please continue to watch for additional opportunities to provide input on future policy issues. And for those of you who are paid sustaining members of DFA, just a reminder to complete the survey for 1 credit of CME for attending this session. If you are a UW student here tonight who is getting underserved pathway credit for this event, please remember to fill out the survey that's being put into the chat right now. In addition, if you enjoyed this Advocacy Grand Round session, please consider supporting DFA's work and impact with a financial gift. The link to donate will be put in the chat. And thank you all for being here and for all you do on behalf of your patients. We hope you will become an official DFA member today and take a look at the benefits of membership on DFA's website. The #1 reason doctors, medical students, and health advocates join DFA is to be with like-minded people who share the same values and priorities. Please remember to follow us on all our socials, Blue Sky, LinkedIn, Facebook, Instagram, to stay up to date with all of DFA's programs, events, and ways to get engaged. Thank you for attending tonight's session, and we hope you have a great rest of your evening.